Good evening. My name is Grant Close. I'd like to welcome everyone to Virtual Journal Club presented by the Society for Pediatric Dermatology and the Pediatric Dermatology Research Alliance. Tonight, we are delighted to welcome Dr. Katrina Abuabara and Dr. John Koo, who will be presenting their recent publications about dermatology and mental health. I'm particularly excited about this timely presentation, given the current mental health crisis facing our country. In October of 2021, the American Academy of Pediatrics declared a national state of emergency in children's mental health. After each presentation, there will be time for the speaker to answer questions from the audience, so please use the chat function in Zoom to submit your questions. There will also be additional time at the end of the Journal Club for question and answers. So without further ado, I will let Dr. Christy Garza-Mayers introduce our first speaker.
Thank you. Our first speaker is Dr. Katrina Abuabara, who is an associate professor of dermatology and epidemiology at the University of California in San Francisco and UC Berkeley School of Public Health. She attended undergrad and has a master's degree in sociology from Stanford University, and then attended medical school at Harvard Medical School, after which she completed an additional master's degree in clinical epidemiology at the University of Pennsylvania, and stayed for dermatology residency and postdoctoral research in dermatoepidemiology. And her research focuses on long-term outcomes and comorbidities of inflammatory skin disease, such as atopic dermatitis. And she'll be talking tonight about her recent publication of the Association of Atopic Dermatitis and Mental Health Outcomes Across Childhood. Thank you for being here.
Thanks for having me. So delighted to be able to share this with all of you. I have some slides that, can you guys, oops, I'm showing the wrong ones, hold on. I think, give me one sec. I have too many PowerPoints open. Sorry, everyone, I thought I had these ready, but let me just. I was trying to get all our SID posters ready last minute before the SID next week, and I didn't forget to, or I didn't get them all closed. Okay, so let's try this one more time. Hopefully this will work this time. Can you guys all see this? Okay, great.
Yes.
Thank you. So this is work that was done by two UCSF med students, Chloe Curran, who unfortunately couldn't be here today because she's an intern and is actually on service at the moment, Faustine Ramirez, who's now a pediatrics resident, and Yang Li, who is a Tulane med student and is still looking to match in dermatology. So a shout out to Yang, Joy Wan, who is a fabulous pediatric dermatologist that you all know, Chuck McCulloch, my biostatistician, mentor and colleague, and Sinead Langan, who's at the London School of Hygiene Tropical Medicine, and Kajal Lewin, who's in the psychiatry department and studies children's mental health. So there's a lot of evidence that has been shown on the association between atopic dermatitis, or AD, and anxiety, depression, and suicidality. And many of us know that AD is most common in children, and childhood and adolescence are times that are critical for the development of mental illness. But most studies on AD had looked at mental health outcomes in adults, and also had been cross-sectional, but the episodic nature of AD makes it really important to examine disease activity and severity over time, rather than just asking people at one time point, hey, have you ever been diagnosed with X? So our objective in this study was to look at the association between AD and internalizing behaviors, I'll define that in a second, and symptoms of depression at multiple time points across childhood and adolescence, and then also to be able to explore potential mediating factors that may explain this association, including asthma, rhinitis, sleep, and inflammation. So we used data from the ALSPAC cohort, which is a population-based birth cohort where they followed about 14,000 women from when they were pregnant into their children into their late 20s now. It's an ongoing cohort. The data we used was up to age 18, and because there was some attrition over time, as you might imagine, in a big study that goes on for decades, the average duration of follow-up for the data I'm showing here is only about 10 years. we looked at the annual period prevalence of AD that was assessed at 11 time points. And they asked standardized questions about flexural dermatitis. And we defined active AD as someone who had responded to flexural dermatitis. They've had dermatitis that was coming and going, it was flexural, present for at least 6 months. The first time they were maybe, and the second time we defined them as actually having AD. We looked at a few different outcomes. We looked at symptoms of depression as measured by the short moods and feelings questionnaire. And that was reported by the child from age 10 to 18. Internalizing behaviors, which are behaviors that are indicative of a child's emotional or psychological state, including depressive behavior, anxious behavior, somatic complaints. Those were measured by the maternal report of the SDQ, the Strengths and Difficulties questionnaire, at 7 time points between age 4 and age 16. So that not everything was asked at every time point in this cohort. So we used the data that were available. And then finally, there was actual clinician diagnoses of depression and anxiety, but those were only done at 1 time point at age 7 using the Developmental Wellbeing Assessment, or DAWA. This is our directed acyclic graph, which is what we like to use in epidemiologic studies to help with our, make very clear our assumptions about how we're setting up our regression models. And what I'm showing you here is our primary association of interest. So we're looking at atopic dermatitis and these mental health outcomes I just described. And all the things in red are potential confounders, things that could be associated with both the exposure and the outcome, but not on the causal pathway. I'll note that the socioeconomic status variable, we had a number of factors that went into this. So it was a pretty robust control for socioeconomic status. The things down here are the potential mediators that might be on the causal pathway. So inflammatory markers, we had at a few time points. We had information on sleep quality and quantity at multiple time points. And then we had data on time updated or concurrent symptoms of allergic rhinitis and asthma. And the reason that these are purple is because I think the directionality of the association between atopic dermatitis and these is not 100% clear. You could argue that the associations might go both ways. And so we modeled them both as mediators and as potential confounders. So a little bit about the cohort. We had a little over 11,000 children total. They were 52% male, almost entirely of white race ethnicity. This is from a small town in Southwest England, although somewhat representative of the general English population. 40% at some time point during follow-up met the definition of atopic dermatitis, 29% asthma, and 14% allergic rhinitis. The annual period prevalence of AD went down from about 20% early on to 15% by age 18. So that's just looking over a 12-month period. Did you have symptoms? And then the number that reported moderate to severe disease in any different time point ranged from 22 to 40%. So this is the Strengths and Difficulties questionnaire. So this was the outcome looking at internalizing behaviors. And here you can see just the distribution from age 4 to age 16, the proportion that met our thresholds. We looked at this both as a linear scale and also using what was defined in the literature as sort of a high level. If you had a score of 4 or greater, used a binary cutoff just to make the results a little more interpretable. And somewhere between 10 to 16% of children met this cutoff at each of these time points. Here is the results for the SMFQ, the Symptoms of Depression Scale. Oops, I don't know why that's jumping around. And here you can see this again is self-reported at older ages. And here the proportions increased with age from about 6% to about 22%. And again, this is using a cutoff score. So here are the primary results for the SMFQ. So you can see this is our adjusted regression model with all those covariates I showed you in the directed acyclic graph. And overall, we found that there was not a significant association with any definite AD. But when you looked at the subtypes by severity, you can see that this did meet significance among those with severe AD. There was a higher odds, about a 2.4-fold increase in the odds of symptoms of depression. And this is using a mixed effects model. So it gives you the average subject-specific effect across all the ages. Though what's interesting to note is that, this was using the cutoff. We also looked at the sort of numerical continuous outcome, and that actually met significance for any AD, although it was a small difference, a 0.3 point higher SMFQ, and for severe disease, a 1.7 point higher score. So then I think it's a 14 question scale. Here are the results for internalizing behaviors from SDQ. The Overall, it was about a 41% increase in the odds of having above the cutoff for SDQ. And again, we saw this increasing risk with more severe AD. Here are the DABO results from age 7. There's a lot on here. We looked at the clinician diagnosis of any depressive diagnosis, any anxiety diagnosis, and then either. And you can see here that at age 7, there are relatively few children that are getting this diagnosis. And it was a subset of the cohort who had the whole interview and clinician diagnosis. So here you can see the confidence intervals are very wide because of the sample size. Even there weren't even enough severe symptoms to get the model to run. But so, it looks like there may be an increased risk, but the confidence intervals were wide. The only place we saw significance was really for the severe disease, but again, still with very wide confidence intervals. So we also looked at inflammatory markers as potential mediators, but we didn't see associations between the limited inflammatory markers we had data on. So that was IL-6 at 9 years and CRP at 9, 16, and 8 years. We also looked at sleep. We have previously published a big paper using this data set on sleep. I think that's in JAMA Peds from a few years ago. And so we used those data and combined it with the mental health outcomes data. And what we found was that there were associations between AD and sleep quality, not quantity. But that only mediated a small percent of the association with the mental health outcomes, about 11% at age 4 and 15% at age 7. So, we're working with existing data. I think there are some advantages of it being longitudinal and having both disease activity and severity, as I described, being really important for AD. But all of our both exposure and outcome data were based on self-report. Although we did have both child and parent report, and there's some data suggests that these are reasonably assessed things. We also had a limited, the cohort. It would be nice to do this in much more diverse settings. So, I think we do see evidence of an association here. And I think it's interesting to see that there wasn't a strong trend in terms of the association becoming much stronger at older ages. For example, the prevalence of that mental health outcomes became larger. We saw the same strength of association when we looked at the cross-sectional results, even at age 4 for the internalizing behaviors. And I think it's important to think about these results in the context of all the new drug development in AD and the outcomes that people look at in these trials. It's obviously very important to understand the safety and the efficacy for the skin, but thinking about how therapeutics can also impact these other important factors of a patient's life, I think is really important. So with that, I'll say thank you. Joy, I have to update my slide. I realized you've moved on, but thanks so much for having me, and I'd be delighted to answer any questions.
Thank you so much for that. I think while some questions come in, questions that I had, how or do you recommend that we incorporate mental health assessments into our clinical practice based off of this work?
I think that's such a hard question, right? Especially not being a pediatric dermatologist. I'm a dermatologist, but I don't get to see kids anymore being at a tertiary center. I focus on adults. And so, this is I think when you have these studies, I think before you can sort of outright recommend that everyone does something, you have to know that it's going to help or it's going to make a difference, and sort of make sure people have the resources to do so. I mean, it's very easy to write a study and conclude, oh yes, this would be a wonderful thing to do, but there's a lot of implementation science around, how you can do it and how it would, what the intervention would mean. So I think it's an important thing to consider. And the American Preventive Services Task Force actually recommends depression screening for everyone over age 12, independent of AD status. So I think that's a pretty clear recommendation that's easy to follow. And there's some pretty short scales that people can use in their practices. So I think it's important, in adolescence that we should probably be doing it anyway as a healthcare system. Whether that should fall specifically on the dermatologist is a good question. I think if you have a patient with severe AD and you're seeing them frequently and there's a way to incorporate it into your practice, it would be a wonderful thing to do, because the evidence is there, at least for teenagers. And but I think it's hard to make blanket recommendations without more evidence on how to do it and how it would help.
Similarly, and this might be even more complex if you think that there's any role for working with psychiatrists or psychologists for patients with atopic dermatitis.
Yeah, I think that'll be a great question for my colleague, John Koo. When I trained at Penn for a while, we had a psychiatrist that came to like our clinic once a month. And I remember that clinic was just overbooked. It was amazing. And, certainly models where that can work, I think for many skin diseases could be really important.
You mentioned at the end sort of the risks and benefits of all of these treatments that are coming down the pipeline for atopic dermatitis. Do you have any thoughts on how you think they will affect mental health outcomes, especially with you thinking about like the JAK inhibitors that are coming along, if you think that it will improve as the eczema improves?
Oh, that's a great question. I've seen more data on dupilumab and where they've looked at like sleep outcomes and quality of life outcomes in adults. Probably people on the call that know the data for kids and better that have probably been involved in some of those trials, but there certainly do seem to be positive impacts on things like sleep and health-related quality of life, at least for dupilumab. I haven't seen those data specifically for the JAK inhibitors yet, but I think it's really important to think about, for this chronic condition, what is the baseline? A lot of our research has been on understanding the long-term disease course and this waxing and waning and development of comorbidities, because it's obviously very important to understand the skin. But if we're going to be putting people on systemic medications, potentially long-term, I would like to know not only, what is it going to do over the next, 12 weeks to year, however long the follow-up of the trial is, but how is it going to impact the long-term disease course and development of comorbidities? Like, will these be disease modifying? And especially for a pediatric population, is there, I don't think we know yet, but is there an advantage to treating people when they first present more aggressively? Would that change the long-term disease course? And we have more data to show. We need more data to show. Do you want to start with a very conservative strategy to all topicals, or would there be some benefit as we have more tools to thinking about more aggressive strategies that may change long-term outcomes?
Thank you. And I think just one final, maybe more technical question. And you might have said this. So the cohort that you used, that was based on assessments of mental health. Are there other kinds of things, I assume, with this massive group of people, is it being used to look at aside from atopic dermatitis?
Yeah, so it's a great cohort. It was designed, it's called the Children in the 90s cohort, and it was designed to understand gene environment interactions. So it was not designed specifically to look at atopic diseases, but they have information on both the mother and the child's genetics, epigenetic methylation profiles, a lot of environmental exposures. And then they interviewed the parents, the teachers, the partners, and the kids almost every year. They asked slightly different questions at some time periods, but it's a really rich data source. And we've leveraged it to try to understand disease course in atopic dermatitis, to look at sleep, to look at smoke exposure, to look at mental health outcomes. We're now doing some work on whether some of the environmental exposures may be mediated by changes in the epigenetic patterns. So there are a lot of really neat things you can do with it.
Awesome. Thank you. Thank you so much again. I think I'll send it back to Dr. Plost.
Thanks for having me.
Thank you so much, Dr. Abuabara. That was a wonderful presentation. And next, I will let Dr. Dawn Eichenfield introduce our second speaker.
Thank you, Dr. Plost. I'm very excited to introduce Dr. John Koo. He is a professor of dermatology at the University of California at San Francisco School of Medicine. He received his medical degree from Harvard in Boston, Massachusetts, where he was a Harvard National Scholar. He then completed an internship and residency in psychiatry at UCLA and then served as chief resident in psychiatry. Afterwards, he completed a residency in dermatology at UCSF, and he's board certified in both psychiatry and dermatology, and is a member of the American Psychiatric Association, as well as the American Academy of Dermatology. He has authored or co-authored more than 300 peer-reviewed articles and books published in many, many prestigious journals like the JAD, as well as other journals. He's also a founding editor of the Journal of Psoriasis and Psoriatic Arthritis. He's been listed in Best Doctors in America continuously for 7 years. He is the recipient of a 2014 American Skin Association Annual Research Award. Best Speaker at the Fall Clinical Symposium, and Best Mentor Award at his home institution. He's also the third recipient of the Lifetime Achievement Award by the National Psoriasis Foundation. He has so many great qualifications, it's just impossible to list them all. I actually first learned about Dr. Koo when I was a medical student. I actually really enjoyed my psychiatry rotation. And then when I rotated in dermatology, everyone was talking about Dr. Koo and was telling me that I should, if I really like psychiatry, I should consider that track. Unfortunately, I didn't take that track and I ended up being a pediatric dermatologist, but I'm very glad that he's here today to better educate us. Thank you.
Dr. Agenfield, thank you for the nice introduction, and everybody, thank you for having me here. Now, Grant is going to help me download and move the slides. So I'm just going to give an overview on the two-part article that is part of today's journal club about pediatric psychodermatology. This is a review article. Next slide, please. So I have no conflict of interest, and this is what the article looked like. And most of the work is actually done by Megan Mosca. He's a medical student, and she's going to be studying dermatology residency in a year and a couple months. Next one, please. So there's part one, and next slide, which is part two. Next slide, please. So what I'm going to do is to just go ahead and talk about some of these conditions that I discussed in these two articles. But just to put it in context, the conditions that I have discussed are all what I might call primary psychiatric problem. What I'm trying to say is that the psychodermatology involving pediatric patients are not limited to primary psychiatric problem, where everything you see is pretty much self-induced. There are other categories, which I don't have time for today, and I did not discuss in these review articles. One is psychophysiologic disorders. This is where stress, often referred to as anxiety, makes real skin disease worse. And that happens, as we know, with atopic dermatitis, other forms of eczema, psoriasis, acne, and so forth. That's one category that I'm not going to discuss today. Another category is secondary psychological problem. And this is where the problem is secondary to having a real skin disease that make them unpresentable. So when people have skin disease that make them feel ugly, then oftentimes people develop anxiety, depression, even social phobia, like patients who have acne, so self-conscious that they refuse to go to school. That's an example of social phobia. That is a secondary psychological consequence of having real skin disease. And then there is this condition that I call primary psychiatric problem, where the problem is really psychiatric. There's nothing wrong with these people's skin, hair, or nail. Everything is self-induced. So trichotillomania is first of the example. And as we know, trichotillomania can hit people who are very young. And when it's very young, there's tendency for these patients, like maybe even preschool, to do it automatically. And luckily, most of those cases resolve spontaneously, but with especially the older patient, we might have to do active intervention. And active intervention ranges anything from behavioral therapy, cognitive behavioral therapy, habit reversal therapy. Now, those are, of course, all conducted by mental health professionals, and possibly use of psychopharmacology, especially anti-obsessive compulsive medications, and sometimes N-acetylcysteine as a dietary, which is a dietary supplement. Next slide, please. Now, skin picking, neurotic excoriation, this is the kind of conditions that's also quite prevalent. And if it involves picking on acne, as you know, we have a special name for that, which is acne excoriate. But people can pick at the skin, mess with the skin for any kind of reasons. Now, next slide, please. Now, historically, the terminology that is often used is neurotic excoriation. But the problem with that terminology is that many of these patients are not neurotic. In fact, in DSM-5, the Diagnostic Statistical Manual 5, we can't even find too much of anything on neurosis because people cannot agree what exactly is neurosis. And more importantly for dermatology practitioners, including pediatric dermatologists, what is really important is what's going on underneath. We don't want to be misled by label. Just because we call it neurotic excoriation in dermatology does not guarantee that the patient has neurosis. In fact, they can have anxiety/stress. They can have the second one, which is depression. They can have obsessive compulsive disorder, which may come closest to maybe the old term of neurosis. And then psychosis. There are people who actually rare, but who actually come to think that they have to do something in order for the skin to, for example, for the hair to grow normally, they actually have to pick at the skin, and that condition is called trichophobia. It's not a phobia, it's actually a psychosis. And then there are some other conditions where, but so what would I recommend? When you see anybody picking on their skin, my recommendation is go ahead and ask them, are you anxious or stressed? Are you depressed? Are you having kind of a compulsion? Now, you cannot ask a patient, are you psychotic? Because even if they're psychotic, they cannot tell you. Because by definition, psychotic patients have no insight. So psychosis, you have to guess, but luckily, psychotic patients among pediatric age group is rare. It's more grown-ups. So anxiety, depression, obsessive compulsive disorder, those are the biggies. And how we treat the condition, whether it's behavioral therapy, psychotherapy, or pharmacology, to a large degree depend on what the underlying reason for skin picking is. If it's stress and anxiety, as dermatologists, if the patient is not willing to go see mental health professional because of something like stigma, then we can consider using anti-anxiety medication. Now, just FYI, we use hydroxyzine, the brand name Atarax. Now, I'm purposely using the brand name for a reason, because hydroxyzine started out as anti-anxiety agent. I don't think too many dermatologists actually know this, but the history of hydroxyzine is that originally its brand name was not Atarax, it was Vistriol. In fact, that name is still used. So what happened was that hydroxyzine was initially recognized as effective anti-anxiety agent. It was especially used for children who are very nervous about getting a procedure like skin biopsy to just calm them down. And then it was found that this medication also helped itch. So when the manufacturer tried to encourage dermatologists to use hydroxyzine, the medication was completely rejected because dermatologists said, this is a psych medication. Dermatologists will not use any kind of psych medication. So the manufacturer became smart. So instead of fighting dermatologists, they came out with a different brand name, which is Atarax. And now it's used commonly and nobody remember that it is still used as an anti-anxiety agent. Now, doxepin, which is also another psychotropic medication, which originally started out as antidepressant, now mostly used by dermatologists in low dose. If you titrate it, it was found to be in head-to-head comparison as effective for anxiety as Valium, which is the benzodiazepine type medication, without being addictive. So hydroxyzine can be used and doxepin can be used in low dose for anxiety. And of course, doxepin can also be used for depression, obsessive compulsive disorder, if that were the problem, and if the patient refused to go see mental health professional, usually because of stigma, and sometimes because insurance doesn't pay reimburse as well for mental health care, then one possible agents that might be usable is paroxetine, which is the brand name Paxil. And then psychosis is pretty rare. Pimozide, which is widely used for delusions or parasitosis, also works for many other kinds of psychosis. And then other possible causes. So one take-home message is, don't be blinded by the label, neurotic excoriation. Go one step further, ask the patient or observe the patient, see which one of these 4 or other things that might be driving the picking on the skin behavior. Next slide, please. Now, onychophagia, this is once again closer to obsessive compulsive disorder and cognitive behavioral therapy or habit reversal therapy, or once again, anti-obsessive compulsive type of medications like paroxetine might be useful, in addition to, of course, mental health professional help. Next slide, please. Dermatitis artefacta. Now, dermatitis artefacta, oftentimes the skin lesions not only look very bizarre, but also when you ask the patient about how did this came about, oftentimes patient cannot tell you. They might give all kinds of what's called hollow or empty history. And also, most likely, patients are going to deny that they're creating these, even though it's so obvious that this is artificially created. Now, one of the big differential with dermatitis artefacta, is it that patients are doing it because they have some kind of a mental problem, or are they doing it deliberately to get secondary gain? And secondary gain can include insurance benefit. Now, if it were deliberately done for secondary gain, then the patient technically have no mental problem whatsoever, because the patient know exactly what they're doing. And then the solution will be law enforcement agency as opposed to physician or psychiatrist. But if they have no apparent secondary gain and they are doing it because of their psychopathology, then that is considered mental illness. Now, the problem with many of these self-induced conditions, not just dermatitis artefacta, is that there may be a temptation to confront the patient. Just tell the patient what is going on. But generally speaking, that's a bad idea. And that is because the thing that is really critical in order to help these people, good rapport. And it's hard to create good rapport when the patients are confronted, even if you are saying that the right thing. So with any of these conditions, a whole lot of diplomacy is required, which also requires time and patience. Next slide, please. Body dysmorphic disorder. Now, body dysmorphic disorder is unfortunately fairly common. In fact, because dermatology is very much involved with cosmetic procedures, more and more of these cases can be seen. And body dysmorphic disorder has a spectrum. Not everybody is completely delusional. Some of the patients might still be able to articulate that their concern might be too excessive. So there's a whole spectrum. But the extreme delusional end of the spectrum, which is sometimes referred to as dysmorphophobia, but once again, that's an old terminology with misnomer. It's not a phobia. Phobia means you're afraid of something. It's actually delusion. So another terminology that is sometimes used when this is at the extreme end is delusions of dysmorphosis. But once again, the easy way of communicating with the patient, which is to just tell them that, oh, they don't look ugly, whatever they're pointing at, it's hardly noticeable. Your nose doesn't look funny. Your acne is only mild. That is not recommended, which I'm sure you all know that, because that is instant invalidation. And so what is the approach? Now, this is once again more of an art of medicine than science of medicine, but the foundation is once again rapport. And what that means is non-judgmental stance, sympathetic, empathetic. And if the patient were to doubt their own perception or interpretation, let the patient articulate it. And oftentimes when people are so concerned about something that is fairly minor or minimal, there are other deeper issues going on. And the patient will not likely to tell you what the deeper issue is until, once again, a good rapport is established. So when I see these kind of patients, my three most important priorities are rapport, rapport, rapport. Whether the patient is truly delusional, whether I would consider using antipsychotic, that is later on, because none of that's going to matter if you don't have rapport. Even if I write a prescription for antipsychotic, if I don't have rapport, then they're probably not going to take it anyway. But if I do have rapport, they might even consider extra help from psychiatrists and accept the referral. Next one, please. So the last one is delusions of parasitosis by proxy. Now, obviously, it's not possible to get a photograph of this, because by proxy means somebody who have delusions of parasitosis, instead of saying that they have problem, they project the delusion onto their children. And sometimes this can be a dangerous situation, because a child might end up getting bathed in pesticide, whole lot of nicks or other harmful chemical put on their skin, in their hair, and left alone, for days. Those things have happened. So Child Protective Service might have to get involved, because oftentimes people with true delusions of parasitosis have no insight. Now, if you as the dermatology provider do not feel comfortable calling the Child Protective Service, what I would recommend is to contact the primary care physician and see if the primary care physician or the pediatrician might be willing to or able to contact the Child Protective Service. And of course, the treatment has to be directed to the parent. And that is sometimes complicated because the parent might not be the designated patient. So these are the primary psychiatric disorder conditions that I have talked about in these two articles. But as I have mentioned at the beginning, psychodermatology is the entire field. It's not just one disease like psoriasis. So I am glad that you're so interested, because in American Academy of Dermatology and other dermatology meetings, generally speaking, psychodermatology is minimally covered. Every year, the number of sessions offered at annual AAD winter meeting is about 400 plus. And typically, the number of psychodermatology sessions out of those 420, 430, 440 sessions is usually only one. So I'm very glad that you're interested in this issue. So anyway, that's all I have to present. Thank you for listening.
Thank you so much, Dr. Koo. That was amazing. I think it stimulated a lot of questions in all of our brains. I'm going to start us out. I think a lot of us as pediatric dermatologists have thought of or have prescribed N-acetylcysteine for our kids. And I think we've probably done it for different indications, sometimes trichotillomania, sometimes for skin picking disorder. I did a literature search once and I saw that the evidence, there's like good case reports and anecdotal evidence, but I saw that the RCTs in kids didn't look as good as it did in adults. I wanted to get your thoughts about this, Dr. Koo.
Well, first of all, you're right that a randomized controlled trial in psychodermatology is very sparse, and as compared to my other area of interest is psoriasis and atopic dermatitis. So the reason for that. So I'm not even 100% sure, if that difference in finding is entirely reliable or not, because the studies are so few. Now, there could certainly be some kind of a physiologic difference, between pediatric age group and grown-up, because age does determine all kinds of things. And, for example, earlier Katrina talked about the atopic dermatitis, but and that's great. And when I look at some of the psychological negative impact of atopic dermatitis myself and compare with psoriasis, that I see more prominent like conduct disorder, which is not what you see in psoriasis. In psoriasis, you might see more like suicidal act. And that's, to me, probably just a different age, because when you're a little kid, it's hard to articulate, your emotion, and you tend to act it out. So of course, you tend to get more conduct disorder. It's hard for a little kid to kill himself or herself. It's easier for the grown-up to do it. So a lot of these, psychodermatology findings are different between children and grown-up. But for N-acetylcysteine, yes, there might very well be a physiologic difference, but unfortunately, I think the number of studies may be only one. And so why does it not show the kind of benefit you see in grown-ups? Is it because children don't consistently take it? Do the kids think that it tastes horrible? I don't know. But yes, you're right, and I'm not exactly sure what the answer is.
Do you so for those of us interested in using it, what kind of dose do you start off with for N-acetylcysteine, and generally for what indications do you think it works well for, and what kind of titration process do you use to go up?
Well, it's actually quite a benign dietary supplement, as you know. And even though some people can get some stomach complaint, but most people have none. So unlike, tricyclic antidepressant or some, or pimozide, I don't usually find that it's really necessary to titrate the dose, but I have to qualify because I don't see too many kids. My psychodermatology patients are practically all grown-ups, and they seem to be able to take it fine. And so I just go by whatever's on the can for direction. And I don't have the number in my head. But so to me, using grown-ups is pretty easy.
So generally for treatment of some of these patients, what's kind of your algorithm for how you see them and how you treat them? Like if you have a patient who you're strongly suspicious that they have, for example, trichotillomania, do you first have them try to start CBT therapy first, and then you would add on like a TCA, or then you would add on an acetylcysteine? Like what kind of treatment algorithm do you generally go by?
So the first thing that I want to know if it's trichotillomania is the patient able to articulate that they're actually doing it or not? And if they deny doing it, then either because they don't trust me yet, so I just have to build trust. Once again, rapport and rapport and rapport and empathy. You know, so then my sessions are essentially devoted to me showing maximum interest and concern and sympathy and empathy to see if they would actually open up and let me know that they are doing it or not. Now, if they are not entirely aware, which does happen rarely, then that is a very strong indication that they're doing it automatically. So in my experience, there are two reasons why people pull out their hair. One is because they're stressed out. The other is because they're bored and they just do it automatically. So then I try to divide between, to see which category the patient belongs. Now, if they're in the bored and do it automatically category, then my first intervention might be really sound ridiculous. I ask them to go to Walgreens or Rite Aid and buy some cheap watch, the digital cheap watch that you can make it chime every hour. And ask them to, what I want to do is try to increase awareness. So I ask the patient that every time it chimes, just look at where your hands are. Now, of course, 9 times out of 10, their hands are doing something else. But lo and behold, suddenly they find themselves actually doing it, and they were not aware of it. And if that happens, then I would ask them to always carry a little notebook, something like, well, it might not be a little notebook, stop doing it, and think about what was the thing that triggered it, if any. And that's behavioral therapy antecedent. Try to identify antecedent. But even if they cannot think of any antecedent like external stress or intrapsychic stress, just the fact that they had to stop doing it because they have to write down something, if you keep on interrupting it, sometimes behavior go to extinct. Now, that's to increase awareness and try to interrupt the behavior. That's for people who do it automatically. Now, what about people who are stressed out, or people who are doing it even more, consciously? Well, for those people, if they have like serious life problem, I urge them to get help from mental health professional, and usually they're not resistant to that, unlike delusional patients. But in terms of when do I use psychopharmacology in addition to N-acetylcysteine, that's when people have very powerful, what I call compulsive urge. When they try to stop doing it themselves and they get defeated every time, because when they don't do it, then this inner restlessness, this inner urge becomes so powerful, it overwhelms their willingness to resist. And that's where the psychopharmacology, usually SSRI, in my hand, mostly paroxetine or Prozac, in higher dose, more like 60 to 80 milligram instead of 20 milligram for depression or 10 milligram for anxiety, that I tend to use. And of course, the most effective is multimodality, N-acetylcysteine, SSRI, and get a behavioral psychologist to help you. That would be most ideal.
Thank you. Thank you. That's very, very, very helpful. I think we've had a couple of different questions about what do you do to try to build rapport with the patients? Like, are there any, during the first visit, if you think that I think they might be psychotic or have something else going on, like delusions of parasitosis, but if we don't want to ask them directly whether that's going on, what types of statements can you use, or how do you build rapport with them? What kind of follow-up do you have with them for the next visits? Because I find that sometimes those patients are also looking for treatments and they want you to give them a medicine. So are there any medicines that you do give them to help them feel better, but more like a placebo medicine?
Yes, in order to build rapport, sometimes I have to give them something before I broach the subject, like antipsychotic or something heavy. And as long as the medication is benign, you're not going to hurt the patient, I don't mind doing that. There is, for example, if I do have a delusional patient, like delusions of parasitosis, and they are not ready to hear anything about oral medication, unless I can tell them that it kills the bugs, which I cannot tell them that. But they really want something, and they already had tons of permethrin. So one medication, it's Urax, crochimeton cream or lotion. It's actually a prescription medicine, and it has dual FDA indication. One is to kill parasite, but the other is to soothe irritable skin. So with a medication like that, they are quite happy because I don't have to prove that they have parasite in order to prescribe it, because obviously all of these delusional patients complain that their skin is irritable. So that's good enough FDA indication to justify prescribing it. And at the same time, patients feel happy that they got something that they were looking for. And so within reason, and not lying and not using anything that's dangerous, yes, I do have to do something like that to strengthen rapport. And once the rapport is there, then I bring in the real helpful medication later. And that is part of empathy. But also the other part of empathy is that frequently these kind of patients with psychological issues might come to your office already looking a little bit defensive from prior experience that were not good with other providers. So when I see these patients, it's understanding that sometimes when you have problem that is not visible, meaning mental problem, psychological problem, then sometimes they do feel like, sometimes imagined, sometimes real, they're being judged. They're being judged negatively, and this is the old hangover, when mental problems are thought to be some kind of a moral failure. I think the stigma that we still have around, they are very sensitive to it. So when I realize that that I am facing a patient with or without skin problem, but big psychological problem, then I have to look twice as interested, twice as fascinated. In fact, if I knew ahead of time, before I go into the room, that this new patient, the nurse already told me, has a big psychological problem or maybe even delusional, I might be kind of tired and a little cranky and grumpy myself, but I can't afford to go in there with that kind of face. So sometimes I put my two hands on my cheek, make sure that I smile, and then I go in with the biggest smile on my face, pretending that I'm meeting my favorite Hollywood star. So that's how I like to start off interaction with these patients.
I think one of the attendings was asking how do you spell Durax, or is it Durax?
Urax, EURAX.
EURAX. Okay, I'll have to look
It's
that up.
available as cream or lotion.
Okay, that's really great. Okay.
The only problem with
Mhm.
Urax is that sometimes stingy insurance don't want to pay for it. It's not cheap.
Gotcha. Okay, I think there's might be a couple of other questions for you, Dr. Koo, in the chat. But I think I'm getting the signal that I'm going to hand it back over to Dr. Ploss, who's going to do a little bit of a wrap up for us. So I'm going to hand back over to him. Thank you again, Dr. Koo.
Oh, thank you. And it was fun.
Thank you again to both of our speakers and for the audience for asking fantastic questions and helping lead this thought-provoking discussion. We hope that you'll join us at our next virtual journal club. You should be receiving, an email survey. So please do take the time to provide that feedback. I think it will come out to your email tomorrow. That'll help us improve Virtual Journal Club going forward. Thank you again to everyone and have a good night.